Thank you and welcome. This is the webinar series from the Eye and Ear Foundation called Sight and Sound Bites. This bi-weekly webinar series started in April of 2020, and the purpose is to highlight the research at the University of Pittsburgh School of Medicine in ophthalmology and otolaryngology. Today's topic is a fun one, but it's also a very interesting and important one. It's the Myopia Story by Mr. Magoo Meets Harry Potter. I'm Lawton Snyder, CEO of the Eye and Ear Foundation. The Eye and Ear Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds the Eye and Ear Foundation provides to support research are only made possible because of philanthropic support, and certainly we appreciate the support that people have given, and we'll certainly welcome anybody who'd like to support the research you're going to hear about today. Some housekeeping rules for this program. You'll recognize it's a Zoom product that we use for this webinar, and it looks like Zoom that you may do with your kids and grandkids, etc. But this for this program, chat is disabled. So what we'll ask you to do is use the question and answer, the Q&A function below. If you roll down to the little bubbles below, you'll see Q&A. You can type your questions anytime during the program. We'll encourage you to do so. We'll read those questions at the end. All questions will be read and answered anonymously. We will ask you to refrain from asking personal health questions, but at the same time, please ask any question you're interested in. What we may do is bypass personal health questions and get back to you with an email later. But if you have any other questions after today's webinar, you can send those to Mr. Craig Smith in your email from your invitation. Tomorrow you'll receive a survey on today's program. Appreciate you filling those out, and we will add people to the mailing list for future webinars. Today's program is going to be brought to you by two wonderful speakers, Dr. Ken Nischal. Dr. Nischal is the Chief of the Division of Pediatric Ophthalmology and Strabismus at Children's Hospital Pittsburgh here in UPMC, and the Director of Pediatric Program Development at the UPMC Eye Center and Professor of Ophthalmology at the University of Pittsburgh School of Medicine. He's going to be joined by Dr. Jay Chhablani. Dr. Chhablani is an Associate Professor of Ophthalmology at the University of Pittsburgh School of Medicine. Dr. Chhablani is a vitreoretina specialist at the University of Pittsburgh Eye Center, and he's published over 350 articles, peer-reviewed journals with focus on the field of choroid. So I'll ask Dr. Nischal to get us started here. And again, welcome everybody, and look forward to a wonderful program.
Thank you so much, Lonnie. Good afternoon, everybody. I think for those of you who remember Mr. Magoo, the reason why we chose this title is Mr. Magoo was very nearsighted, and he really found it difficult to get around. He didn't want to accept that he was nearsighted, but he clearly had vision problems. And Harry Potter wore glasses because he was nearsighted, and I'm hoping that by the end of the session today, after you've heard Dr. Chhablani speak and myself speak, you'll see that understanding the magic of science sometimes can help us progress the delivery of care that we want to deliver to our patients. These are my disclosures. I'm an advisor regarding myopia control for Carl Zeiss and for Nevercar, but none of that is pertinent to the talk today. So this is what myopia or being nearsighted or being short-sighted means. It means you can't see in the distance and everything looks blurred. I always show this image when I'm talking about the eye, because it's difficult always to remember what we are relating to. So the pupil is the dark spot in the middle of the colored part of the eye. That's over here. And then you have the ciliary body. Now this is the part that does accommodating. So when it contracts, the muscle becomes fatter so that you can actually see closer up. And we're going to be talking about the retina here, the choroid, and the sclera. And that, of course, is the optic nerve. I think what we don't realize, perhaps, is that myopia is the commonest ocular disorder worldwide, with an increasing prevalence over the past decades, predominantly in East Asia, but now throughout Europe and the Americas. It's predicted that approximately half of the world's population will be myopic by 2050, and that as much as 10% will be highly myopic. That's more than -5. High myopia is associated with excessive eyeball growth, as Dr. Chhablani will explain to you, and this may lead to sight-threatening complications when you're older. So myopia is a major public health concern, and it poses a heavy health and economic burden to society. Any of you who have children who are nearsighted know that glasses are not cheap to buy. So there's an economic burden as well. So I'm going to hand over now to Dr. Chhablani.
Thanks, Dr. Nischal. Thanks for introducing the subject. Before I really get onto the complications associated with myopia, let us talk a little bit about what myopia is. So myopia is nearsightedness. As you can see on the picture, the top picture, which shows that the light rays are entering the eye, but they are not reaching to the retina, but they are actually just focused in front of the retina. But if you look at the middle picture, it is a picture of hyperopia, where the light rays are not focused on the retina, but they are focusing behind the retina. And the bottom picture shows that astigmatism, when these things are happening at different meridians, we call it as astigmatism. Today, we are just going to focus primarily on myopia because this is definitely a much serious problem associated with a lot of complication. Myself being a retina specialist, this is one of the very common disease which we see in our retina clinics. Let's talk about the complications of myopia. There are many complications, but I just brought only four here to talk about today. One is retinal detachment, cataract, glaucoma, and most important is myopic maculopathy. If you can see the numbers next to these pictures, it shows that what is the high risk compared to a normal healthy eye. If you are a high myope, you are almost 4 to 15 times higher risk for developing a retinal detachment. If you are a high myope, then you are at risk of 2 to 5 times higher risk of developing cataract, and you have higher risk of glaucoma, which is almost 2 to 3 times. And what we see in our clinics most commonly because of high myopia is something called as myopic maculopathy, which is almost 60 folds if you are a very high myope. And we are going to talk about this a little bit more in detail. Let's start with retinal detachment. As you can see the picture on the left, it shows that there is a complete retinal detachment where you can see that the whole retina is folded. This is something which we call it as giant retinal tear. These patients present to us with an acute vision loss, where you can see that the retina is completely detached. And the only way to fix this retina is the surgical treatment. As you can see the picture on the right, which is a post-operative picture, which shows that the retina has been put in place after doing vitrectomy. You can see the laser scars all around 360 degrees, and we are successful in attaching the retina. However, we have to remember that considering retinal detachment surgeries are very challenging, they are more challenging in patients who have high myopia. And one of the biggest challenge, at least on the patient side, is that in spite of having a good anatomical success, that is, the doctor is saying that the surgery was really successful, the retina is completely attached, but in spite of good attachment, there is very high possibility that you will not be able to recover vision 100%. So that's why it is very important that we see these patients in an urgent care. We try to fix the retina as soon as possible so we are able to recover the vision as much as possible. Let's move on to the second disease, which is again pretty unique to myopia, that is choroidal neovascularization associated with myopia. I'm sure the audience are very much aware of age-related macular degeneration and something called as wet AMD, which is very common disease. There is a lot of awareness, but a similar kind of choroidal neovascular membrane or the bleeding under the retina is very much possible if you have high myopia. As you can see on the picture on the top, that is A, which shows that there is a big patch of subretinal hemorrhage, which leads to loss of central vision. The retina is attached, but here you can see that you have a large subretinal hemorrhage right in the center. And these are various imaging techniques which we use. This is the OCT in the center, which shows that there is blood, there is fluid, and these patients usually require multiple anti-VEGF injections, the same treatment what we offer for wet AMD. And eventually our goal is to reduce the leakage, reduce the bleeding, and the patients end up having no activity. But you can see the bottom pictures, it leads to a lot of scarring in the center. That's why it is very important, more important than wet AMD, that we see these patients as soon as possible when we start treating them as soon as possible. This is one of the very common disease in our clinics as well. Talking about degenerative myopia, that is myopic macular degeneration, you can see the variety of pictures from patients who have myopia. If you really look at the picture A, you are seeing that this is not pretty normal. This is like pretty normal looking retina, but you can make out that this is a myopic eye. And as you go from A to F, you will see that how the degenerative changes. The white part is actually the sclera, which is behind the retina, behind the choroid. And as the myopia progresses, you can see that how these patches are increasing right in the center. And these patients tend to have central vision loss, and very unfortunately, we still do not have any treatment to prevent this progression. And we believe that there is definitely a genetic association with this particular variant or this particular representation. But the most important part, again, is to see these patients early, try to find the complications much earlier, and treat as much as you can. But these degenerative changes, we still do not have any clear treatment to prevent this progression. Let's move on to the next, again, interesting complication, which is glaucoma. This is a very unique thing in myopia, that these patients have this abnormal disc. As you can see the picture, this is the picture of an optic nerve which carries the impulses to the brain. So if you really look at this picture, you are seeing that yes, there are these myopic changes right here, but there are some additional changes which are suggestive of glaucoma. The challenge of diagnosing glaucoma in these myopic patients is that A, their disc is already abnormal, so their diagnosis of glaucoma itself is very challenging. And many of these tests which we do to diagnose glaucoma, they really don't they don't really are made for these very high myopes. So the clinical examination and the experience of the glaucoma specialist plays a very crucial role in diagnosing glaucoma in these high myopic patients. And more important is that we need to treat them much more carefully, because their IOP control, their glaucoma medications could be slightly different than normal glaucomatous patients. Again, the important part is see a glaucoma specialist sooner and then try to prevent the progression of this disease. Cataract is very common. Cataract is a very common disease. However, we need to know that patients who have high myopia tend to develop cataract much earlier compared to their age-matched healthy subjects. And for surgeons, the cataract surgery in high myopia could be very challenging. The very reason is that because these are very high, longer eyeballs, which actually makes the whole anatomy very difficult for a surgeon. The zonules, the ligaments which are supporting the lens, they could be weak. And the overall the surgical challenges are quite high compared to a healthy subject. That's why it is important to see your ophthalmologist who specializes in cataract surgery, and make sure that you get it done on time. Uh, with this, I would request Dr. Nischal to talk about how do we actually prevent having these complications, and how treating myopia and preventing progression is so important. And Dr. Nischal, please.
Thank you, Jay. That was really sobering. Really, it reminds me why I enjoy doing pediatrics and not doing adults. I'd rather try and prevent problems from occurring then have to deal with them. And I think it's important at this stage for the audience to realize that there are two types of myopia. There's what we call pathological myopia, where the myopia is greater than 2 diopters under the age of 2 years, and there are other accompanying signs. It could be nystagmus when the eyes are wobbling, night vision problems, glaucoma, or connective tissue disorders. This talk that I'm going to give you is not pertaining to pathologic myopia in terms of myopia due to an underlying disease. I'm talking about the progressive myopia of childhood. So right now, if you're not sure if you're nearsighted or not, even if you don't want to take your glasses off, if you look through your glasses and everything becomes smaller, then you're nearsighted because you've got a concave lens in front of you, in front of your eyes. And this normally starts around 6 to 9 years of age, and it progresses till around 16 or 17 because the eye is growing. And that's what we are going to talk about. In fact, in 12-year-old children, the prevalence of myopia varies around the world, but what's becoming very clear is that it is becoming more and more prevalent, even in places like the United States and parts of Southeast Asia. But in Eastern Asia, it's already very high. So what are the factors that influence refractive development? And there are genetic factors and environmental factors. And I think this is important for us to understand. If you have both parents that are myopic, the child is 4 to 5 times more likely to be myopic than if neither of the child's parents are myopic. And this was shown, goodness me, over 25 years ago. Then there came a turning point in terms of genetics. The Consortium for Refractive Error and Myopia, CREAM, and a direct-to-consumer genotyping company, 23andMe, you know, we've heard of them, they independently looked at subjects of European ancestry, and they reported, CREAM actually reported some patients of Southeast Asian ancestry as well. And the two studies, completely designed separately, came up with the same 25 genetic loci across the genome that were responsible with a higher rate of myopia. And that really was a turning point because now we could start to look at genes. So there is no doubt that there is a genetic influence. But, and I'm going to give you the example of my family, I'm -5, my wife is -6, but none of our children wear glasses. Why? Because I've been aware of the effects of how to control myopic progression since 1994. And so I put those environmental factors in play for my kids. What are those environmental effects? Well, before I talk about them, I want to talk about my mother. My mother used to say to me, don't read too much, your eyes will become weak. Don't wear your glasses all the time, your eyes will get weak, and go play outside, your eyes will get stronger. And of course, I ignored her because we all ignore what our mothers tell us. But is there any fact or science to back what my mother said? See, that's the magic of science and understanding. To understand what is really going on, we have to understand this process called emmetropization. Emmetropization is the process, it's an active process that's vision dependent, whereby when a child is born, the eye is small, and as the child gets older, the eye gets bigger, but the refractive error goes towards a genetically and environmentally modified 0. I'm going to say that again, genetically and environmentally modified 0. So it could be -1 is your aim, the eye's aim, or it could be +1. It depends on the genetics and the environment. And there's so many studies. I mean, this could be a whole 2-hour talk. There are so many studies, but emmetropization requires light-dependent vision. If you take normal macaque monkeys, then as they mature in age and days, they end up towards a +2.5, slightly hyperopic. But if you rear the same monkeys or the same type of monkeys in the dark, you see that they don't emmetropize. So active vision plays a role in emmetropization, which we all have to undergo. Now, If you suture the lid of one eye of these macaque monkeys, their eyeball gets longer. And the longer your eyeball, the more nearsighted you are. Does that happen in humans? Well, yes, sometimes babies are born with a hemangioma or a droopy lid. And in these babies, the form deprivation, because you're depriving the form of the shape on the back of the eye, is disrupted, and they get axial myopia. So the animal experiment is relived, redemonstrated in human disease. So what about form deprivation? What's really interesting is that it does not require the visual signal to leave the eye. So if you cut the nerve, it'll still happen. It doesn't need sympathetic or parasympathetic inputs into the eye. So cutting the ciliary nerve, the superior cervical ganglion in animal models does not affect the axial myopia, the axial elongation when you suture the lid. It is a vision-dependent mechanism that dominates refractive development, which is located in the eye. And that's really important. So my mother used to say, don't read too much, your eyes will get weak. I could show you so many papers that show that if you are somebody who does near work, you're going to end up being nearsighted. And if you're somebody who wants to look in the distance, you end up as not being nearsighted. But the first piece of work was as far back as 1882. Recent pieces of work done in Taiwan looked at university professors' children, all myopic. Farmers' children, all hyperopic. That makes sense, right? There's an adaptive mechanism. If I'm reading all the time, then my eye says, wait a minute, why should I have to focus all the time? I'll just naturally get long enough so that I'm nearsighted, and therefore I don't have to put any effort in. Because basically, the human system wants to do as little work as possible to get the best out of its function. So that makes sense. So she was right. Don't read too much, your eyes will get weak. Well, we have to read, we have to do something. So maybe there's something else we can do, and we'll come back to that. She said, don't wear your glasses all the time, your eyes will get weak. Have a look at these macaque monkey experiments. If you put +9, which is a hyperopic correction, in front of these neonatal macaque monkeys, they became hyperopic. If you put -6, they became myopic. So the lenses that you are wearing while your eye is growing affects what happens to your eye. So let me show you why. When you have light rays that fall at the back of the eye, you see perfectly. But if they fall behind the eye, we call that hyperopic defocus. And if they fall in front of the eye, we call it myopic defocus. In animal experiments, it's been shown that if you do hyperopic defocus, the eye tries to grow to catch the light rays, so you become more myopic. But if you have myopic defocus, the eye tends to slow growing. If you look at the traditional lenses that we wear, what I wore when I was 11, they give you a perfect focus centrally, but they put you into hyperopic defocus peripherally. And we know that it is the peripheral retina that drives the growth of the eye during those crucial years between 6 and 9 and 17. Now you might be saying, hang on, you have to see. So what do? We'll come to that in a minute. So don't wear your glasses all the time, my mother said, your eyes will get weak. She was right. Go play outside, your eyes will get stronger. Well, again, an absolute tsunami of evidence showing that the more time you spend in light, daylight, the better the protective effects against myopia. Reductions in the absolute amount of outdoor activities occur 3 years prior to the onset of myopia. So if we're worried about children becoming myopic between the ages of 6 to 9, we have to make sure kids get out or at least have light coming in through the windows at an earlier age. This paper in 2012 showed without a shadow of a doubt that the overall findings indicated increasing time spent outdoors may be a simple strategy by which to reduce the risk of developing myopia. This study showed that it was independent of the reduction in near work and independent of exercise. So you didn't have to be running around. You just had to be outdoors. It's not clear, however, if once the myopia starts, the outdoor hours have the same effect. So we've got to be more proactive. I can tell you the number of times my wife and my mother, who was alive then, used to tell me off for sticking my kids outside, whether it was hot or cold, and saying, spend 2 hours out there, it'll be good for you. So all of this shows us that increasing the daily light exposure, look at that blue line, means that you reduce the growth of the eye and therefore the myopia. Simple things. Again, paper after paper showing exactly the same thing. Extra outdoor time at school slowed myopic shift in non-myopic eyes, but did not significantly slow progression in myopic eyes. So if you have children or grandchildren who are under the age of 10, they're not myopic, make sure they get 2 hours daylight. So go play outside, she was right. All right, so I've told you some of the basic science. What can we do to slow the progression of myopia? Well, we can get at least 2 hours of daylight exposure. It's not ultraviolet exposure, it's not UV light, it's lux. Lux from outside is much greater than the lux of the lights in here. What else can we do? We can make lenses to prevent peripheral hyperopic blur. And the first multifocal contact lens that's FDA approved, it's called MySight, is available. What's not FDA approved yet are spectacle lenses, one called MyoVision and the other one called Stellest. But if you look at the studies, especially of Stellest, which are glasses lenses from China, they're phenomenal. Because what these lenses do, both the contact lens and the glasses lenses, they take the peripheral hyperopic blur, and because of the way they're made, they put the eye into a myopic blur, which makes the retina want to stop growing. So it's a phenomenal time for us because we can control the growth of the eye. Now, Ortho Keratology has been around for ages. And what that does is that you fit a contact lens at night, it changes the shape of the cornea so that during the day, when no contact lens is worn, you have the same effect of making it a myopic blur, peripheral blur, than a hyperopic one. So let me come to the last thing that's really become popular, atropine eye drops. Atropine is a muscarinic antagonist. It blocks muscarinic receptors in the ciliary muscle. And people had thought when you do near work, your eye's accommodating. So if you could stop the accommodation, maybe it arrests myopia. So that's been around for ages. And the trouble with atropine, any of you have ever had it, it makes it very blurred. So, people have to wear reading glasses as well. Well, they started to do some control studies. And what they showed, this was the ATOM study, that 42 to 61% of children treated showed no myopic progression, right? 8% of the control group showed no myopic progression, and the control group are in black. But the ones who got the myopia, the atropine, you were reducing the rates of myopic progression. Think about that. A drop reduces the rates of myopic progression. The problem, however, was they still got blur, so they needed glasses. This was the ATOM study, and they looked at monocular 1% topical atropine versus placebo, but the fact that you were blurring the children was a problem. And the other fact was that there was a rebound effect. When you stopped the atropine, you rebounded in growth. So then they did the ATOM-2 study, and I'm very proud of this study because the lead author and the principal investigator is Audrey Cheer, who was my fellow in 2001. And so what I know is the inner workings of this study. And what they showed was that 0.01% that has no effect on blur had less of an effect on myopic progression, but there was very little rebound. So the effects of atropine concentration certainly affect how much you can control it, but 0.01% gives you control, but doesn't get a rebound effect. And this is what this study shows. And that's why it's such an important study. So as a result of all of this, we set up the Myopia Treatment Center at Children's Hospital of Pittsburgh and the Department of Ophthalmology. And there's a consensus statement at the World Society of Pediatric Ophthalmology and Strabismus that gives you all this information, if you'd like it, at hand. So what do we do now? We do environmental interventions, 2 hours daylight. We do atropine drops once daily. We will consider multifocal contact lenses, multifocal spectacle lenses if we can get them, Ortho Keratology, or a combination of these interventions. Now, what I think is really interesting is this. I said at the beginning that this control of the growth of the eye was in the eye. And we're beginning to understand that the visual stimulus leads to cellular and biochemical changes in the retina, and then in the retinal pigment epithelium and the choroid, which leads to scleral remodeling and growth, which leads to altered ocular growth and refractive state of the eye. It means that we should be able to manipulate this if we can evaluate it. And Jay, at this point, I'd like to ask you, you're a world reputation on the choroid. What do we know about children's choroid, and specifically children who have no myopia versus those that do, versus those that are hyperopic?
Thanks, Ken. Very unfortunately, we really don't have much data on choroid in children. We know almost nothing about choroid in less than 5 years, because I have done a lot of work, but my work has stopped somewhere in adults. So we know nothing. The challenge used to be that there were no imaging techniques. That's why we could not image them. But now we have a lot of advanced imaging techniques, which needs a lot of research resources, where we can actually have handheld OCTs where we can image the patients. That requires a lot of research in coming future.
My hope, Jay, is that I'm hoping in the not too distant future, maybe in the next 5 years, we'll have enough funding to firstly do a quick genetic evaluation of the 25 loci that we know are involved with a predisposition to myopia. Right. Then look at the different treatment algorithms that we would personalize to the patient once we know what their choroidal thickness is, because I think the choroidal thickness does play a predisposing role to how they might respond to the different treatments. Right. The thing that interests me is we don't know how atropine 0.01% works. People think it's acting on the matrix metalloproteinases. These are enzymes that are at the sclera, and that somehow it's affecting that because it only affects axial growth. Because if we can prevent the axial growth, I'm assume I'm right in saying that we prevent the complications that you so beautifully demonstrated at the beginning of the talk.
Ken, one more. I was just curious that do you think that there is some way by electrodiagnostic we can find out the impact in myopia? I think that you published long ago, but do we know the reasons for those findings?
Yeah, so thank you for reminding me that I'm old. I appreciate it. 23 years ago, we looked at we looked at patients who had long eyeballs but had vision that was corrected. So by long, 27 millimeters or more. The eyeballs should be around 23 to 24 millimeters. And in these individuals, the electroretinogram, which measures how the retina functions electrophysiology, was abnormal compared to normal patients with no myopia. So the mere growth of the eye causes a stretching effect. And so I think, Jay, going back to your question, I think that we have, the great thing is, we have Dr. Al-Kiliasis, who's one of the world's leading pediatric electrophysiologists. And if we could evaluate the different levels of retinal circuitry, the on-off pathways. I think we could also correlate that with choroidal thickness, with the genetic loci, and then try and make a personalized map to really try and control the growth of the eye.
Yeah, that would be really cool. And I think this is, I'm just thinking that this is somewhere relates even with the poor visual field as well in the periphery in high myopes. Everything is
Completely.
falling in place.
Completely. And the thing that I love about this field is I love the fact that we as ophthalmologists can work with our optometry counterparts and make it an inclusive project, because optometrists see more children with nearsightedness than ophthalmologists do, because they don't normally have anything else that's sight threatening. But if we can educate the general public, make this a public health initiative, and say, look, if both father and mother are nearsighted, and your child is not nearsighted, we can do environmental interventions early, and then we can be more aggressive about starting these simple preventions like lenses. I would prefer to use lenses in younger children than contact lenses, and then if necessary, using atropine eye drops. I think it needs a concerted effort with, and it needs basic scientists, ophthalmologists, and optometrists working together.
Okay.
Fantastic. I have to throw in a question here for related to this. This Ben Franklin quote, I believe, is, an ounce of prevention is worth a pound of cure. So what you're saying essentially is there are things that we can do to prevent the typical myopic vision progression, but are we also saying that those same prevention techniques can impact those other comorbidities of this condition, such as the glaucoma and the other retinal type of detachment and other risks that you are with? Do we have the science to show that all the way through as well, or is that?
So if I'll let Jay answer, get the final answer of this. But the thing is, for me, Lonnie, the longer the eyeball, the greater the risk of the complications. So if you stop the eyeball getting long, then you should not get the complications. If somebody has a 24 millimeter eyeball and is -1, their risk of the complications that Jay showed is much lower than someone who's -5 or greater and has an axial length of 26, 27, 28, 29 millimeters. Jay, would you agree with that?
Absolutely. It's just the longer eyeball which is the problem, and all the complications are just because the eyeball is longer.
Fantastic.
Lonnie, one of the things is you remember that there was this big thing about, when if you do fetal medicine, you can find things in the fetus that tell you what's going to happen when you're middle age in terms of your heart. And we just have been poor in communicating with the public that there are things that we can do for the eyes in terms of myopia very early on that will have a profound effect on what happens to you when you're middle-aged or mature, more mature than that.
Gentlemen, thank you. I see a lot of questions coming in. Some were started when we first started getting the program, but Ken, are any more to present before we get to the questions?
No, I'm looking forward to the questions.
Okay, great. Maybe if your presentation's done, we'll kind of close that so we can, be on screen a little bigger.
So before we do that, can I just say my hope is that with the magic of our understanding of the basic science, that we can banish the Mr. Magoos and have everybody with supervision in the future. That's my great hope. So on that note, I will escape. And you want me to stop sharing?
Please, yeah, there we go. Okay, great. Well, thank you. I think, Mr. Magoo, didn't listen to his mother very well, apparently. But okay, let me start with the first question here. And we got, as I said, many of them. and I'll refrain from using my reading glasses so I don't get dependent on any vision correction as much as I can. Why is global myopia increasing? Is it, as you showed in your slides that it is on the increase? Why is that increasing?
I mean, parents always say to me that can I tell their children not to only spend 1 hour on their screens? I mean, look, we know that the more near work you do, the greater the risk of myopia. So I have no doubt that as we become a more literate world globally, that the time spent reading closer up than we used to has increased, and I think that is an influence. What I don't know is if diet has an influence. I have no idea. I don't know. Some people have said processed foods have an influence. There's no evidence whatsoever that is the case. But I think that what we do environmentally does have an effect on what we are doing, what's happening, why we're seeing that global myopic increase. The other interesting thing is that in Eastern Asia, there's no doubt that they have a genetic predisposition that is different to the European and African ancestries and the Southeast Asian ones. Jay?
Thank you. This question is obviously a very well-informed question. As mentioned at the 2020 Global Myopia Symposium, MD is currently the only cause of blindness without established treatment. Could you elaborate on when the causes of or what the causes of lack of treatment are?
Should I take this?
Yeah, please.
I think that unfortunately the very reason is that because this was underdiagnosed and we still don't know the cause. And I think the focus has still not been the macular degeneration, but always has been an age-related macular degeneration. That's why I think this disease has been ignored. But as Ken was mentioning, that there is an increase in myopia, and that's why we still have very limited resources towards the myopia research compared to age-related AMD research or diabetic retinopathy research. We still have very less resources towards it. I think this is one of the most important reason for lack of available treatment.
Well, are there any current research? Is there any current research going on in developing a treatment for dry atrophy MD, as there are only anti-VEGF injections for myopic CNV? Are there any ongoing trials in defining a treatment for dry MMD?
Again, a very well-informed question. And as we all have learned that this anti-VEGF therapy also was borrowed from wet AMD into the myopic CNV. And we are having a lot of studies for dry AMD, but unfortunately, again, there is no trials or studies or molecules are coming up to prevent dry or myopic macular degeneration. So unfortunately, there is no treatment for myopic maculopathy underway. That's a very sad affair of mine.
So another, and this is all from the same individual who actually sent these ahead of time, but in Denmark, 7-methylhexathene has been approved and available via national insurance's treatment for myopia for control in children. What is your opinion of this treatment?
So methylxanthine was first reported in 2008, where they looked at 68 myopic patients, and they showed that it did retard the axial growth. Part of the problem is that when they use it's an oral medication. It's not a drop, and it's an alkaloid. So there's been a reluctance to use it while it's available. And in fact, if people are interested, there's a webinar on the WSPOS channel on YouTube about myopia, and a Danish counterpart, Lotte Wallander, was on that. And what they're saying is there's a reluctance to use a systemic therapy when topical therapies are available, because it being an alkaloid, it may have side effects that we're not aware of, because the initial study was done in adults, not in children.
Very good. I think this is an interesting question. In addition to spending time outdoors, is it helpful to use more light indoors in your home to avoid progression of myopia?
So no, that's a very good question. And the reason is that the amount of lux that you get outdoors is greater than any lux you can get, even with the brightest bulbs, by factors of thousands. So no, the answer is no.
Oh, interesting. So what do you do for children as impressive that they do not appear to be myopic?
Yeah, so that's Al Biglan asking that question. So what I did was I got told off a lot by my wife and my mother because I used to stick them outside, come rain, shine, or cold weather, and go out with them at least 2 hours a day. Now the evidence for the next bit is a bit ropey, but I wouldn't let them read in bed at night. And I stopped them using their iPads and their iPhones in their bedrooms, because we haven't been able to prove this, but in neonatal macaque monkeys, if you rear them in monochromatic light, which is the equivalent of reading in dim light, they get axial myopia because their eyeball grows. So based on those studies, I figured that if I stopped them reading in dim light, that would be protective. And then my eldest son went into -3/4 when he was about 11. But I only let him wear it when he was in school and would make him stop wearing it when he was out of school. And he actually now is -1/2. He actually dropped.
Wow.
My youngest son would never listen to me. He's now a -1, but that's over the last 3 years. And my daughter doesn't wear any glasses, but they can get around. I'm a -5, and all of a sudden, Lorne, you look like the handsomest man I've ever seen. If I put the glasses back on, reality hits. You're even more handsome. So, Al, I hope that's answered your question.
Very good. Are there types of behaviors for senior individuals, 60 plus, to consider to slow progression of myopia?
Jay?
I don't think that we have that evidence, or I doubt that it's changeable at that age. That is the very reason Ken spoke about preventing the progression, because once you have an established myopia, it is almost impossible to prevent it.
At what age is our myopia established, or
Yeah, so by 21.
at 21? Okay.
I mean, sometimes you can get a diopter, maybe 1 diopter of progression after 21, but it's that age, between 6 and 16 or 17.
Well, and I think I'll answer this question. It says, should seniors go outside and play every day for 2 hours as well? Absolutely.
Absolutely.
That's I think everybody should go out and play for 2 hours. So what would be the clinical criteria to offer those innovative treatments to kids with myopia? Any particular defect?
So the Myopia Treatment Center, I mean, we are becoming flooded, actually. We are becoming more and more and more available. And so the criteria, so we've created this algorithm. In fact, we were talking about it this morning. If you have a child who is, let's say, 7 and -1, and both parents are over -5, I would immediately start the environmental factors and see them 6 months later. And if there was any progression, offer atropine or the spectacle lenses, which we are not available at the moment, or offer them the contact lens. If the child was -3 and 7, we definitely offer that straight away. So it really is dependent on what's going on in the family, so the genetics, what's going on with the child, and we're really becoming more and more, not, I wouldn't say aggressive, but accessible to those treatments.
And it for astigmatism as well? That was part of the question?
Yeah, and you can do it for astigmatism too. So I can see an anonymous attendee asking if we should undercorrect their prescription. So the studies have been done. Undercorrecting the prescription of somebody who's myopic has no effect on retarding the growth. I used to think it did. And in fact, in my practice 20 years ago, did undercorrect. but it does not have the same effect. I mean, of course, the reason why we were doing it is if you undercorrect, while it might be a little blurry in the center, there's less hyperopic blur in the periphery. But you don't want that. You want a myopic blur. You want the retina not to have any reason to grow faster to catch the light rays.
Interesting. Okay. It's you don't want to undercorrect, but essentially you really don't want to wear your glasses essentially all the time.
Yeah.
So it's
give them a break.
It's a break. Okay. So what do you think of the Bates method? Sunning the closed eye, avoiding the eye strain, relaxation, taking breaks from reading, etc.
So the Bates method is it's a very popular book. It's sold up generation upon generation. Some people swear by it, and the only study that's been done using the Bates method showed that it had no effect beyond placebo effect.
Okay.
I can see this. Do you have atropine study in enrolled patients? So, in fact, we have become the first center in the United States to do a commercial atropine study. We're in the throes of getting everything going with that, but atropine can be compounded, the 0.01%. So we have a number of patients that are already on treatment.
What age is considered for that?
So any age. So
Any age.
six and above.
Okay. First in the U.S. That's very interesting to know.
With this particular product that's actually manufactured in Singapore. So they're using it in Singapore and Taiwan, and they've got an FDA approved study, and we're the first site in the United States.
Okay. We may answer this question here offline, just when we get personal questions. As I said, we may follow up with those later. How long is CRT needed to prevent myopia?
So that's corneal reshaping therapy, the Ortho Keratology. So we're very lucky. We have Craig Luchansky, who is a real expert in this. You normally have to do it at least 3 or 4 years to get the effects. Sometimes you have to do it a little bit longer, but it depends on the response to the initial corneal reshaping therapy. But Craig has a clinic that he does, and he's very, very well versed and very well experienced in this.
So can a baby develop myopia by the mother during pregnancy not spending enough time outside, especially if both parents are non-myopic?
See, that question's coming from my molecular biologist who works with me, and only Baresh would ask that question. I don't know, but I think the answer is no. Thank you, Baresh, for that very interesting question. I don't know. I don't think so.
Okay.
I mean, it's a different environment, right? So remember, you can only get emmetropization because you're relatively in dark in the womb. So the translucency of light is different.
Okay. So for someone who's just turned 60 and has severe myopia and has had retinal detachments, is there anything that they can do to avoid further complications and problems?
I think seeing your doctor regularly is most important, because there will be subtle changes which are happening, say even myopic maculopathy or choroidal neovascularization. These are very subtle changes which your physician would be able to pick up by doing tests. And I think seeing them regularly is more important. And yeah, being aware about the symptoms of any change in vision, any change in reading vision, flashes, floaters, or anything which is not usual, you need to see a retina specialist immediately.
Okay. Actually, I'm going to go back to this question. I thought we might answer later, because I think we can tackle this one. For someone who has high myopia and they're wondering if there's an association to being tall. I'm interested in this too, guys. And also association with intelligence. Is there was what they were told correct?
Well, I want to say that I think that the person who's asking the question, that their retinal surgeon has fabulous bedside manner.
Most of the retina surgeons have to have a good bedside manner.
I don't know that there is an association between height and also high intelligence, but yeah, I'm not aware of anything that's been looked at. I don't know, Jay, if you are.
Yeah, Marfan's could be one way of correlating with the height and detachment, and they're more prone for some having these weak spots, but it is not like a direct association with height and intelligence and detachment.
I mean, you mentioned Marfan's, but that's a connective tissue disorder.
Yeah,
I mean, they get myopia because their lenses are not in the right place and their eyes are big, but it's because their connective tissue is weak. So it's a different story. And in them, we have no evidence that atropine works. And if children have a retinal disease that's giving them myopia, I avoid atropine because at this moment in time, I don't know how atropine works. And I don't want to be affecting retina that's already not normal.
I gotcha. Yeah. I think in kind of answering even this last question, the UPMC specialist the presenters mentioned is essentially the Myopia Center, and yours truly, Ken Nischal, and so just maybe if you would tell our listeners about that, just exactly what that is and how, if anybody's interested in following up with you related to that.
If you go to the CHP website and just put Myopia Treatment Center, a whole page comes up and tells you who works here, who's doing the myopia treatment. If you've accumulated more birthdays than 21, then you want to really go to Dr. Chhablani's or the Vitreoretinal website page at the Department of Ophthalmology. I do see one question, and I think we have a couple of minutes, is how long do you recommend children taking the atropine drop? So I think that's a superb question. If I get stability where they're getting no growth for 2 years, then I'll stop the atropine. Now, that means that you are on atropine drops for a significant time, but they're one drop at night, every night when they go to bed. And so we find most kids tolerate that very well. Now, you might say, that's a drop for a long time. It's true. Oh, CHP, sorry, is Children's Hospital of Pittsburgh. But you might say that's a long time, and that's true. But if you think about avoiding a lifetime of potential complications from high myopia, I feel it's a small price to pay.
Yeah, as you said before, I mean, I think an ounce prevention certainly worth a pound of cure. I mean, what a great answer it is to actually improving vision by essentially just really being upfront and paying attention to these things that can prevent it. So, Ken, you should have listened to your mother for sure. I think we should all listen to our mothers for sure. But thank you for a very, very informative talk. There is one more question if we have time, and we do have a couple minutes. Maybe this is one that Jay. So his 50-year-old with history of retinal detachments, glaucoma, etc. I'm sure the answer isn't, is it a lost cause? I think the answer is to see a specialist. So,
Lonnie, can I just say, for that particular question, it is so important to see someone who will consider genetic evaluation. -20 is a large number, and I think that seeing somebody like Jay or one of his partners, because we have access to ophthalmic genetic counselors, will be very helpful to help understand what's going on. And the same for the last question as well. The advice is to see someone who not only is a good ocular person, but someone who has a handle on genetics. And myself and Dr. Sahel, we do ocular genetics. And I think that because of that, it sort of rubbed off on our colleagues within retina and the other specialties. What we need and what we're so grateful for the community in Pittsburgh and those listening around the world, we need to consolidate so that we can get a proper program going of this research about what's happening with the choroid and what's happening with the genetics, because insurance companies won't cover that. And we need that so that we can personalize the treatment so that we can really tighten this down. So I really want to thank you and the Ioneer Institute. You do such a great, foundation, do such a great job for us. And I'm sure Jay would echo that. Thank you very much for allowing us to speak with you.
Thank you. Well, and to end that, of course, anybody interested in how they can help, please contact us at the Ioneer Foundation. You find our website, www.ioneer.org. Thank you. Have a wonderful afternoon, everybody. Gentlemen, wonderful presentation. And always a joy is spending time with you.
Thank you so
Bye.
much.
Have a good day.
You too.